If we have any questions from the audience, just invite you to come up to the microphone. Yeah, no, maybe I'll start. I mean, we've really seen the full spectrum here from, the very high tech, the nice towers that give you that amazing quality, and we've seen the lower tech that is more commonly used in really a global context. And so I'd just be really interested in the panel's thoughts on how can we meet in the middle, and how close are we to meeting in the middle where we can use the same technology regardless of where we want to telementor. And maybe a second part to that question is a technology that really maximizes the use of bandwidth so that we can forget about cables and move more to that cellular environment that I think, Paul, you maybe mentioned in your presentation. So open it to the panel. Brian, why don't we start with you?
Well, I don't know if I'm the technology guru, but I will say that I think the technology is important. I think wireless technology is getting us where we want to go, and we're seeing this rapid progression. When we first started working on our wearable stuff, there were actually no iPads. And so we were using little handheld LCD projectors. By the time we kind of finished speccing that out, the iPad came away. We threw it all in the trash can. So things are moving fast, and I think technology is going to work itself out. That's why we wanted to put together for SAGES, let's put some specs together and let the world of technology figure out how to get that to us, and that will work. What I think is missed, though, is this framework of an educational experience. And the reason why I want to emphasize that is the technology becomes less critical if you've wrapped this in a curriculum that is using this as one piece of the curriculum, for instance. And so one concept that we've been working on is I actually want to get you through the telementoring part of this whole experience as quickly as possible and get you into asynchronous coaching on a recorded video that we do that, right? Because that doesn't have to be done same time. You don't have to be out of your OR to do that. So if we can wrap this in a curriculum, prepare you as best we can for the intraoperative experience, get you as quickly through the telementoring, which is really the intense part, and get you into video coaching, I think that's the paradigm.
Nin, with the sleeve gastrectomy experience, there was an international component and a component that was within North America. So do you have any comments on the differences between the two? And
well, as you can see, as long as you have a good Wi-Fi, you can actually connect. So it's actually very amazing that the image that you can see internationally versus US is essentially the same. Some hospital will have firewall, so you have to be careful about that. You're gonna have to talk to your individual hospital IT department to kind of figure out the firewall and how to get around the firewall. So that's the only limitation there.
And how did you manage? So you talked about that like mentoring was just in state, but what did you do with the international sites? Is it just not an issue?
At the current time, no, it's not an issue internationally, but in state, yes, that's very important.
Yeah.
Can I just make a comment? Because I don't know if most people realize that, but the state medical boards, for the most part, do not differentiate telemedicine and telementoring. That's just all considered part of the same bucket. And telemedicine, as I talked about, is the direct care of patients, so that's managed by state medical boards. You need to be licensed in that state, and you can't practice across state lines. And so that's why we have this problem. And we need to overcome that problem. We can't scale this. We can't leverage time zones. If Nin is mentoring someone on the East Coast, then he can do that in off hours, and before he has to go to the operating room, that kind of stuff. So that's a big hurdle that we're trying to overcome, and that's why we want SAGES involved with this, to leverage a society to try to help do that.
Yes.
Good evening. My name is Obos Sekaise from UT Houston. I want to thank the panel for an amazing lecture. Dr. Duncan, you never fail to amaze. This question is for Ninh Nguyen. What about the bidirectional mentoring? So if somebody from India or the Far East wants to mentor someone like myself in a new procedure like a SADI or a SIPS, can you speak on that?
Yeah, so then it's the onus is put on your institution to have the availability of the equipment to perform that telementoring. So, you know, for example, if you utilize one of the equipment that's you've seen up here, which is the Visitor One, so your institution is going to have to be able to acquire that equipment, which is right now is relatively costly. From the other end, meaning from someone from India, all you need is a laptop, iPhone or iPad. It truly doesn't matter. So that part is easier. You know, the more complex part is really your institution. So yes, you can do it.
And one more question for the first two speakers. Why? I was about to ask you why Haiti, and then as you went on with your presentation, I saw the answer to that question. I just wanted to applaud you on that. And where do you see the future of Haiti and other Caribbean countries in terms of go global? Can we expand what you've done in Haiti to other Caribbean countries and South American countries and so forth, and African countries?
Thank you. Yeah, for me, why Haiti was, somebody just asked me, and I said yes. You know, can you come and help? I said yes, and once I went there, I just wanted to keep going back because of the need. So we've talked about a lot today, going from teleeducation, which is really pretty simple. It just takes coordination, but it doesn't take a great deal of equipment. But telementoring globally is still going to be, in my opinion, a challenge because you have to get the relationships first. So it's going to take, for example, an organization like SAGES, it's going to take some sort of a surgeon champion who has an interest in that particular country and is willing to go there, establish relationships, find out who the champions are in that country. Some countries it's not going to work. I mean, in our global committee, we have to do a site visit and determine whether we're capable of developing those relationships, and those relationships can be trusted. Once you have that, then you have the ingredients to be able to go beyond even teleeducation, but getting into telementoring, which of course requires the relationships. I don't think we're having, Mike can comment on, we had problems early on, even with teleeducation, with the firewall that was mentioned earlier. A lot of our institutions don't allow telecommunication to take place beyond their hospitals. Mike, you've had to go to some of our sites to solve some of those problems. Do you have any comments on that?
Well, that's evolving as far as the local IT departments and connectivity capabilities. But you really have to have someone technical come and tell the IT department that it's okay, that this application is not going to harm their network and cause any troubles. And that's one of the challenges in a lot of hospitals around. On the receive sides, it's not really a challenge because, like they were saying, a laptop, an iPhone, simpler technology. But definitely you need buy-in on the hospital side in order to get the systems to actually communicate bidirectionally and work.
Just a quick comment on having someone from outside the U.S. beam into the U.S. and be able to mentor. I mean, that's again another example of wanting to leverage expertise and resources. But that person needs to be licensed in the state of Texas, and your hospital is going to want to speak to what their credentials are, and each hospital kind of manages that individually. We also consent our patients so that they know someone else is in the room with us and is part of it. So you have to think about all of those things as you're doing it.
I think that's an important point with respect to the consent, and I think we've mentioned the word privacy and HIPAA compliance already several times, and on the international stage, a lot of the software that you talked about, some of it may have been HIPAA compliant, but certainly some of it isn't. I wonder, Mike, whether you could comment, or Justin, on any software that you've either worked with or that that is coming that would allow us to take telementoring to the next level at a portable level, but that would also meet all of the privacy standards so that we could use it in the U.S. or internationally as well.
I suppose I can start. I don't know what's on the horizon in terms of what we might be able to use on the global stage, but I will say that in the resource poor areas that we've had to partner with ministries of health in each of those countries and make very clear what the exact technologies are that we use. So we have permissions to be able to use them in their countries.
And there are several integration versions of things like WebEx or Skype or Zoom or various other of these software codecs out there that you can work in the API on them and enable end-to-end encryption. It may not be readily available from the off-the-shelf free product, but you can get it to work by changing some things in the back end of it.
Yes.
Hello, I'm Anand from Johns Hopkins, and thank you for the wonderful talks. I had a question or a comment on what do you think of, so everybody spoke about technology. What do you think about more advanced technology or more smarter technology, wherein, for example, artificial intelligence, which is showing promise in processing videos, can maybe augment such telementoring when the expertise or the remote mentor is not always available, but in an asynchronous setting, the virtual machine or the AI can provide some local mentoring.
Sure, I can speak to that a little bit. It's a great comment, and it's a potential opportunity to leverage computing power to add an intelligence to our OR. One example that we've started tentatively down the road on with SAGES is identifying, using Google Brain and partnering with them to identify the critical view of safety during lap chole, and to give a surgeon feedback on, red, yellow, green. Green, I agree, that's critical view of safety, go ahead. Yellow, do some more dissection, not so sure. Red, not happy. So there is that ability to kind of provide an augmented reality that could provide prompts, warnings, increase awareness for the OR team, that kind of thing. There's a lot happening in that world in general, but that's a simple example of how computing intelligence might be able to do that kind of thing.
If you just look at what's going on with self-driving cars, I mean, you can just see that the future is there, that, at some point your tele-astronaut's going to do our job, because the reality is that a robot only makes that mistake when it's programmed one time. It's after Tesla had this car that crashed that was self-driving, they went right back to the drawing board and they changed out how they use radar data and how they use, situational data, and they said it's never going to happen again that same way. So we make mistakes, and every time we train a new surgeon, they repeat those mistakes. But if you start using artificial intelligence, and we can take away that, and hopefully there'll always be a human component to that, because that's our connection to the patients. But it's going to be like your lane change warning that says there's a car there. It's like, don't cut that, that's the cystic duct. Don't cut that, that's the ureter. And especially with immunofluorescence and all these other technologies, we're going to get there.
Thank you.
One more question, and then we'll wrap up.
Okay, so I have a follow-up question to that as well. So my name's Ann Mayavich. I'm a professor at the University of Texas at Dallas, and I'm an engineer, do research related to surgical coaching. Hi, we're friends from Johns Hopkins. So I guess my question is, when it comes to the mentoring, has anyone studied or have you noticed the style of coaching and feedback that people provide most often? Is it procedural related? Is it related to the style of how someone's doing something? Is it related to safety things, like you mentioned, the critical view? Do you have any comments on what type, style of coaching is most relevant and important in this kind of situation?
So I think there are several different types of metrics that they use for determining operative performance competency and proficiency, and that's a big controversy and a big topic of interest in surgical education. We chose one specific one because we felt like we could replicate it very easily, and there's a lot of literature about it. But I think the real answer to your question is that just about every situation has its own set of needs that are unique and the population that you're working with. So if it's fully trained surgeons who have already been familiar with this one type of operation you're teaching, then they probably need a very directed set of commentary. But if we're talking about residents who are just broadly learning about general surgery, then certainly that would require a much more broad categorization.
So it's a great question. This is an area that's ripe for discovery because there's a lot unknown about it. One of the things that's interesting about surgeons is many of us have spent much of our career teaching, and we've had no formal training in how to do that. And so in this environment, in this remote environment, you have to pay a lot more attention to that. I gave one simple example of dual task interference, which we were intentionally creating, not knowing any better. What we have engaged in for our mentors is they go through a train the trainers program where they taught a very specific way to communicate. It's not just the intraoperative part. It uses a framework that we call set, dialogue, and closure. So before you engage in the operation, let's talk about what our goals are, what our objectives are, how we're going to communicate together. We spend a lot of time, for instance, defining the word stop. Because stop doesn't mean stop and drop when we're doing laparoscopy, because I might want to make a teaching moment and I want to take a picture of that and then we're going to talk about it. Or it doesn't mean do 3 more steps and stop, because it might be a safety issue that I'm worried about and you need to stop immediately. And so we'll actually define that. And then there's a very specific way that we communicate during the procedure, and I mentioned a little bit of that in the vignette. So we don't talk and operate at the same time. If I want to make a teaching moment, we're going to stop and we're going to have a teaching moment, and then we're going to go back and operate. And then there's closure around that as well. And so we've borrowed this framework from surgeon training in the UK, and we find it really effective in this environment. In the UK, they had developed this training framework to try to keep expert surgeons from taking over the operation when they were teaching in the OR, and that's perfect for telementoring, where I can't take over the operation. And so, but there's a lot more to be done. We've been trying to study what's the best way to use telestration, for instance, and what's the right workflow for that. There is nothing out there on that. So if that's what you're talking about, kind of these communication protocols and how do you do this effectively, that's a wide open area.
I definitely think that that's the most important thing too, is that, as Dr. Duncan said before, is that the reality is all the tech is secondary. It's the relationships that you have to have. Good teachers, some of it is intrinsic, but some of it can also be coached. That it's a relationship between a mentor and a mentee that needs to be very predefined in what you want to accomplish. So I think we'll wrap it up with that. So on behalf of Alan and myself, we'd like to thank the speakers for sharing their experiences, giving us insight and inspiration, and leading us forward. Telementoring will definitely help us at home to truly mentor and ensure true quality of care. It'll make the world smaller and help our surgeon partners in less advantaged locations get better. So we appreciate you guys for joining us.